Okay, should we round the corner for the last leg of this journey? This is the, I guess, the fourth quadrant. I was thinking the combination of this just really positive sense of humility and exhilaration of the journey that we've been on together. And I was thinking about this theme of knowing and doing and not knowing and doing, or not, knowing and not doing, and sort of the chasm and the whole prospect of connecting these two. So we're really rounding the corner here on delivery, healthcare delivery, some of the hurdles, the opportunities, the challenges, and all of that. So we have 5 wonderful speakers. Really, I think it's going to be a great drive to the finish line here through the afternoon. And our first guest speaker is Dr. Prendergast from the Mayo Clinic, and I will turn it over to you.
So first of all, I really want to say thanks to Larry Gold, my friend, for the invitation to come. I didn't really realize what this conference was like, and this morning I had a real revelation. I'll tell you, let me just explain a couple of things to you. First of all, I'm living in Rochester, Minnesota for 40 winters. Any of you have been to Rochester, Minnesota, and you think I'm intelligent, dispel it. But I'm married to a Norwegian-Dutch woman, and my children, therefore, are sort of jam-Dutch-Wegian because I'm from Jamaica. And that picture that Evelyn Resch showed this morning with a black guy, and I thought maybe I should go home. And the problem that I had was further that, when you think about it, given the juxtaposition of Evelyn Resch's talk to lunch, and I'm thinking I should go home, you draw the imagery for yourself. I know Sherry from before, Sharon Terry. She came up to me on that wonderful talk she gave this morning. And then the other thing that I was curious about is that I am Jamaican. And despite the fact that I have lived in Rochester, Minnesota for 40 winters, I still have this habit of Caribbean genetic-induced movement. And I figured, I'm not going to be in place here. And then I see Rick Guidotti. And I'm going, holy crap, this is the right environment for me here. So that's my introduction to all this very, very serious subject. I wish I wasn't talking about cancer right now, because quite frankly, the imagery from Evelyn Resch is killing me. So the title, and Larry Gold immediately caught on to this when he saw this, because he saw the Problems, Premise, and Promise of Personalized Oncology, and immediately equated it to P4 oncology, and some of you may get the inside joke there. But Larry, I almost had seven iteration with pervasive, promise, etc. I escaped myself. And the subject I'm talking about is really interesting to me because I really trained as an internist and then a PhD biophysics, especially protein biochemistry, biophysics, and Gilliman, and I know Greg Petsko is going to be here. I got into oncology because we ran into a problem at Mayo, and I was brought in as sort of Mr. Fix-It for the cancer center, and I became cancer center director for 13 years. Now, this, however, was a task that was personally important to me. And the reason is that in my own family, on my mother's side, there were 8 kids, 6 girls and 2 boys, and every single one of them died of cancer. Moreover, I discovered I went to medical school for strange and bizarre reasons, which I won't tell you about because that's just too embarrassing. I wasn't a particularly attentive medical student. I didn't think I really wanted to do medicine. I tried to drop out 3 times, and I succeeded in dropping out once, the last time, for a few months anyway. And the reason was that I was acting house officer in pediatrics, and I had a little boy who came in on a Friday, was diagnosed with acute lymphocytic leukemia, a joyful, delightful little kid called David. I took to him immediately, took his blood, got it processed. He had ALL. Went away for the weekend, came back on Monday, and the kids in the yard were playing blind man's buff. And David was it. And he couldn't see the kids. Yeah, you normally put a mask on. He couldn't see the kids playing. except that David wasn't wearing a mask, but he couldn't see the kids. Took him into the room, got the ophthalmoscope, looked in his eyes, and his eyes were filled with leukemic cells. His retinal completely full with leukemic cells. He was completely blind. I then had the task of giving David intrathecal methotrexate for 5 days because that's the only thing that we had at the time. That was in 1968. And David died exactly 3 days later on Friday. And that just totally disequilibrated me. Let me fast forward about 15 years, actually more like 40 years. I got a telephone call from a friend of mine who used to play soccer for me. I used to coach soccer on the 19 traveling team. And he said, "Frank, I got a problem. I have chronic myeloid leukemia. I've just been diagnosed." He is now one of the most prominent people in the United Nations dealing with issues of international injustice. We brought him in. He was treated. And within 3 months, he was in complete remission, marvels of Gleevec. Then about 3 weeks ago, I got another telephone call, and this is the legacy of being cancer center director because I get a lot of telephone calls. I refer about 3 to 5 patients to Mayo per week, even though I don't practice anymore. And this was a completely different story. This was a son of a friend, or son-in-law of a friend, who called and said, "My son-in-law was perfectly well until last week on Friday. And he got a bout of abdominal pain, went to his doctor, and his doctor said, 'You have a big lump in your belly. We need to do some tests. I need him to come to Mayo.' We brought him in, did a bone marrow, and he has a form of what is called Burkitt's lymphoma. He has double-hit Burkitt's lymphoma. And that is, in fact, a sentence of death. And I think what a lot of people don't realize is just how fast cancer can move. And in this particular instance, for example, even with treatment and initial response, you can die in a very short time. And then last little anecdote to tell you was that when I was in Jamaica, we had a condition there which is a cousin of HIV called HTLV, HTLV1. And HTLV1 predisposes to 2 diseases. The first is a fatal form of neuropathy. And we used to call it Jamaican neuropathy. And then we called it ginger neuropathy. And we gave it all sorts of names. And now it's just a T-cell-based neuropathy that is caused by HTLV, and that is uniformly fatal. But it causes another disease. It causes a form of leukemia. It's a T-cell leukemia. And the dramatic feature of this disease is these patients often come in with huge necks. And they're toxic and they're sick. And at that time, the only drug we had was Cytoxan, which is a chemotherapeutic agent. You'd give them a dose of Cytoxan, and within 24 hours, bang, the neck would just shrink back to normal, and the patient would look absolutely fine. Normal. Neck is small, and they would feel good. The fevers are gone, the night sweats are gone, etc. They'd look great. And 3 weeks later, they'd be dead. Now, unfortunately, in that latter condition, things have virtually not improved at all. So here it is, we have a condition which we call cancer. It's protein, it has no specific definition, and 40 years after I graduated from medical school, which is actually 42 at this point in time, I'm much older than you think. No comment is necessary, okay? But I'm not as old as Larry. Okay. 40 years later, how much progress have we really made? I would argue that in many cases, like the case of CML, we've made a great deal of progress, but in many other cases, we've not. And one of the reasons is we need to rethink in my assessment what cancer is and how we deal with it. And if you haven't read this book by Siddhartha Mukherjee, it's called The Emperor of All Maladies, just won the Pulitzer Prize about 2 weeks ago, you should. The byline is a biography of cancer, and it gives this wonderful history in time, dating all the way back to Galen and to the ancient Greeks, all the way forward to the modern day. It's a very personal story told by Siddhartha Mukherjee, who is an oncologist, about his feelings about cancer, how it evolved, what it is, and what it isn't, and about the problems that we face. And the fundamental issue in my assessment with cancer after all these years, and especially now really become de facto an oncologist after 13 years as cancer center director, is that the disease, there is no such thing as cancer. There is every such thing as cancer. That is a completely heterogeneous chameleon of a disease that is profoundly variable from organ to organ, from tissue to tissue, from individual to individual. And therefore, that no single solution is going to satisfy at all. At the end, I'll give you an idea of what I think going forward, and it may sound like an advertisement for somebody in the room, but we'll see, that we need a lot more creativity. But let us just take a very quick tour through cancer for the next few minutes. And it's going to be high throughput because, in fact, I have a lot to talk about in a short time. But I also just want to point out something to you that this is the book that I told you about coming up here. This is the book here. It's called The Emperor of All Maladies by Siddhartha Mukherjee. So let me give you something that's going to scare the bejesus out of some of you. This is a biopsy from a patient who had lung cancer. And it typically illustrates the problem that clinicians, and let's face it, the problem for cancer is not for the clinician, it's for the patient. Okay? This is the typical problem that the patient with cancer faces and the doctor tries to contend with. So here's a patient with a biopsy of a tumor, and you can see, let me take this, and you can see what happens here. This is a single biopsy under a microscope, and what you see here is that, in fact, there's one area up here that looks like this. It's called an adenocarcinoma. There's another area that looks down here. It's called a small cell carcinoma. Now, these conditions have very, very different prognoses if they occur apparently just by themselves. And they also have very, very different treatments. But now what you have is that you have one cancer here, another cancer here, in the same patient at the same time, in the same lesion. Now, small cell down here metastasizes extremely quickly. So that staging, typical staging, stage 1, stage 2, stage 3, and stage 4 often means nothing. By the time you have it, it's spread. It spreads your lymph nodes. It may have spread elsewhere in your body as well. Adenocarcinomas tend to be a little less aggressive in that regard, but also they spread. So when you come and have this here, what in God's name do you treat? There is, in fact, no mechanism for treating this at all. And one of the realities, for example, is that with adenocarcinomas and with squamous cell carcinomas, bronchogenic carcinomas, so-called non-small cell lung cancers, you often do surgery to take the tumor out, to debulk, maybe even to take the lymph nodes out. But in fact, there's no such recommendation for small cell because, in fact, it's pervasive. Now, this illustrates, I think, very graphically the issue about cancer heterogeneity. And the histologic heterogeneity is mirrored. I'm going to give you an illustration just by analogy. So this is a gene profile, if you wish. Now, this is an idealized, it's not real, it's an idealized picture. It's a technique called mate-pair technology applied to the genomics of cancer. And if, in fact, and each of these columns here represents, in principle, a different patient. Now, if the diseases were identical in each patient, and by the way, all of these nominal patients here have the same diagnosis, then what you would find is that the pattern, just look at the pattern, don't try to understand the detail, the patterns would be identical. However, in reality, when you look at patients with cancer, and these are just 6 patients approximately, and you see there are 1, 2, 3, 4, 5, about 10 patients represented by each column, there is no similarity whatsoever among them. And you can see there are some regions here that have a little bit of overlap and a little bit of overlap between patient 1, 2, 3, and 4. And you can see here that there are other regions that you have some measure, but there is no single common feature. Now, what is happening now in the cancer world is that as we've gone into whole genome sequencing, and we have sequenced 40 cases of ovarian cancer, and there is no identity among any of those 40 cases. There are virtually no similarities at all. Some Australians recently reported on 50 cases of breast cancer whole genome sequence, 1,800 mutations found, no identity whatsoever. And you heard Sharon talk about that this morning in part. So the problem of heterogeneity is not just different cancers in the same patient, is that even within a single diagnosis of cancer, there is no genetic identity whatsoever. Now, how pervasive this is going to be across all different types of cancers from all different organs, we don't know. But it is emerging, in fact, that that lack of commonality is far more common than people realize. And it may well be that in every malignancy, and I hope this isn't true because it's going to make life really difficult, you're not going to find any identity. And this is highly, highly problematic. I'll come back to you with some more hopeful comments in a moment. So that is the first issue, and the polyclonality word refers to the fact that there is a belief that cancer arises from a single cell, and the progeny of that cell is called a clone. And if you have multiple clones, you get polyclonal disease. If you have a single clone, you get monoclonal disease. It used to be thought, for example, that cancers like, or diseases, malignancies like multiple myeloma, were in fact monoclonal. They're not. The evidence is coming clear that in fact that's just not true. And I'll show you some other features of this that should also scare you. Now, one of the critical issues then for any cancer is to ask the question, what is the proliferative potential? From what I've told you before, if you don't know what the cancer is, how do you know a priori what the proliferative potential is? So that's one thing. I'm just going to go through these very quickly. Similarly, metastatic potential. We know that small cell, which is a morphologic definition, will in fact metastasize. It will move and spread much more quickly. But a priori, there's no way to tell what the metastatic potential is. There are genetic signatures now beginning to emerge that at least give us some idea, for example, mutations in the cadherin gene, that this is likely to metastasize much more quickly. There are several other genetic signatures that are coming forth, but in fact, there's no hard and fast rule to tell you what the metastatic potential is. And remember, cancer kills you not so much by local growth, although some obviously do, especially in the brain, but it kills you because of metastasis. This term here, minimal residual disease. So you have a cancer, it's cut out, and you don't really know whether the cancer is spread or not because you can't find it. And then this word here, you hear people say the cancer came back. My contention is it never left. The fact is that there was minimal residual disease after the initial treatment, and that the recurrence is occurring because that minimal residual disease is now growing out and making itself manifest. Immunosuppression. We grow older. Again, this is a statistics that's going to scare the bejesus out of some of you. Connie Wynn and Jorg Goranzi, who are now at Emory University, have done a calculation that points out very clearly that your immune system is finite, that it has finite capacity. That by age 65, on average, each of us has only 17 to 20% of the immune capacity remaining. It is no wonder then that after age 65, when you get influenza in the winter, you have a very high risk of dying because you have such poor immune capacity remaining. There's a hypothesis, and it's never been proven because it's very difficult to prove, but a priori it makes sense, that each of us on a daily basis is breeding malignant diseases constantly, simply because our cells are dividing and because the risk of malignancy rises as your cells divide through errors in the divisional process and the duplication of your DNA. The immune system, the argument goes, surveils the body, finds those malefactors, if you wish, destroys them, and saves us from being walking cancer clots. When the immune system fails, then in fact cancer emerges more easily and more effectively. And what is even more insidious is the word, basically what is emerging is that cancers uniformly cause immunosuppression. In other words, it's not just a feature that you get the cancer because your immune capacity is down, but you get active immunosuppression. And the data are becoming incontrovertible that that is true. Even brain cancer, which is nominally removed from the bloodstream, also causes immune suppression. We have lots of data to prove that particular point. This is an area of great interest to me because of what I call informed self-preservation. So you get immune suppression as a function of aging. You also get immune suppression as a function of disease, especially chronic disease, chronic viral disease, chronic inflammation, all of which we know predispose to cancer. And Siddhartha Mukherjee goes into that point very clearly. Cancer is in many ways a disease of the aging individual, although you get pediatric cancers. But the origin of pediatric cancers are somewhat different. So this immunosuppression is a big deal. The last part of this whole sorry story is the incredible complexity of the disease. The number of mutations, the number of abnormalities, the number of pathways, the number of networks that are abnormal are prodigious. And one of the issues that we face is if we have all this cellular heterogeneity, we have a little problem because we can't really tell where exactly the cancer arises. And what we do know is that as the cancer progresses, the genetic heterogeneity, the biochemical heterogeneity increases. Now, just a quick, forget all the stuff on the side, just follow this little bit here, because this is where I'm going to go in a second. So we talked about genetics, and you all have read a lot about it. Remember that the genes give rise to proteins. The proteins give rise to pathways and networks. And then what you see as expression, either of our normal physiognomy or normal appearance or whatever have you, is in fact the product eventually starting with the genes. What we now are realizing that there's a similar paradigm fundamentally for cancer. Cancer, after all, is a normal growth of cells. It's inability to control cell growth. And it follows the same exact paradigm. The interesting feature of this, I want to just focus for a second on here, is that the actors in this whole story are not just the genes. In fact, these are the controlling elements, but the real factors that cause the disease finally are the proteins. It is the proteins that cause function. It is the proteins that trigger growth. It's the proteins that control growth. And it is the abnormality of the proteins occasioned by abnormality in the genes that really causes disease. I want you to hold that thought because we're going to come back to it at the end. So here's one of the challenges for a physician and therefore for the patient. What in God's name do you interrogate? I've told you you have histologic heterogeneity, you have cellular heterogeneity, and even within a single tumor you have a heterogeneity. So what should you interrogate? So normally what you do now is you get a piece of, you're told you have a cancer, you have a breast cancer, you get it cut out, they do a section of it, they look at it, they say, yes, it's a breast cancer. From the morphology, they can give it some names like basal, basolateral cancer, or whatever have you. But looking at that and listening to what I've just told you is that the right tissue to interrogate, the whole tumor, or should you be interrogating pieces of the tumor in different regions? In other words, should it be so-called macrodissected, or should you look under the microscope and see areas that may be a little bit different and interrogate those? Or are there stem cells, so-called progenitor cells within the tumor, which you should try to isolate? Max Wischer has done a lot of work at the University of Michigan on breast cancer stem cells. There are a number of other individuals who are trying to look, for example, at brain cancer stem cells. They are real, they're there, we've duplicated that work. And by the way, one of the interesting things about brain cancer stem cells is that they're different depending on what medium you grow them in. The character of the cells change. And therefore, if you grow them in the wrong media and you start interrogating them and getting all these sophisticated genomic tests, what in God's name are you testing? Further is this issue of metastasis. You would make the assumption if you have metastasis in your liver, one in your lung, one in your brain, that they're all the same disease. What is really distressing is that in multiple myeloma, again, this is something that's come out in the last few years, patient with multiple myeloma treated very successfully initially, myeloma comes back, and now you have myeloma nodules in your abdomen, your chest, in your neck, and you take them out and you find that there are 3 completely different myelomas. Again, polyclonality. And then further, what data do you collect? And we're sort of iterating towards where I want to go with all of this in the final analysis. We have become enamored with genomics. That's what I have done for the last several years at Mayo, is to build a fairly substantial genomic enterprise. We now can do whole genome sequencing. We can do any of the genetic tests that anybody is doing anywhere. Can't do it on the scale of Broad Institute or BGI. And we are doing extensive analyses. This is the most successful biotechnology business at the moment in terms of instruments in the world. But the question really is, what in the genomics should we measure? Should we do whole genome sequencing, array CGH, copy number variations, mRNA expression, transcriptomes, exome, whole exome sequencing? Should we in fact be interrogating the epigenome? Or perhaps we should be doing a lot more histology. Maybe we can do genomically driven histology. Maybe we should be looking at the metabolome, all these omics. Maybe we should also, let's go back here, we should also be looking at the proteome. Now the difficulty that we have is it depends critically on whether you're trying to do a diagnosis. Diagnosis means the identification of a disease, or whether you're trying to do a prognosis or look at predictive medicine, or whether you're trying to stratify the disease or whatever have you, because the fundamental approach that you use differs. So for simple diagnosis, you really don't need much more than histology, which is what has always been done. However, if you start to think about stratifying, then you're going to need all this stuff. Well, maybe you should do everything. But who can afford that? And again, we'll come back to that at the end. And then, how do we determine therapy? And this is where the big bugbear lies, because the fundamental premise for cancer up to now has been we got to treat the patient. And somebody said this morning, let's stop talking about cure and start talking about treatments, because that's exactly correct. You're not likely to cure. But in any case, how on earth do you even treat the patient? Largely, it's been based on empirical information over time, huge clinical trials, usually with highly toxic materials, and you see which patients respond. And what is distressing to me is that treatments have been so empirical over time that on average, the vast majority of cancers, you do not get much better than 20 to 30% drug response, especially to chemotherapy. The time that you get the best response is if you catch the disease early and you can cut it out. But that doesn't work particularly well in the brain. Some of us can do without a brain. In fact, I dare say some of us do very well. But the fundamental reality is that you can take surgery only so far. And once the disease has gone beyond stage 1 and stage 2, surgery becomes increasingly difficult and increasingly poorly responsive. So whether you do, and this is why you need to read Mukherjee's book, because extirpative radical surgery is on its way out. It just simply was barbaric. Then it was the best we had to offer. Neoadjuvant treatment before surgery is still in. This is where you use chemical agents to try to shrink a tumor before you do the surgery. Adjuvant is treatment afterwards. And in fact, these I lump all under surgery, because surgery remains one of the best options for the treatment of cancer. Radiotherapy, local, is palliative substantially. So when you start building your big, expensive proton beam instruments, remember that you're seldom ever going to cure a patient with that. You're going to do palliation. It's important, but at $200 million, it better be very effective. Systemic radiotherapy is an interesting thought, because some cancers are extremely sensitive to radiotherapy, for example, multiple myeloma. And if you could find a way to disseminate the radiation throughout the body, it would be a great therapy, because in fact it's extremely effective treatment for diseases like multiple myeloma. And then the issue here is so-called targeted therapy, tailored therapy, pharmacogenomic optimization. You've all heard these terms. These are all particularly useful. Targeted therapy may in fact be maybe the best therapy of all. One of the most effective ways to kill something you don't know what it really is, and it's very, very different in different cells and highly different heterogeneous, is in fact to use a poison. But you've got to target a poison. And this was the basis of so-called magic bullet concept of how you treat cancer. The problem is nobody has learned how to do that very effectively. Tailored therapy is a matter of choosing the therapy, and this is where this N of 1 issue comes in. Because what I've really been telling you all along is that you have to treat the cancer patient as a singular individual, and that you cannot apply, in these modern times anyway, you should not be applying some sort of shotgun approach. You've got to find a way to deal with the uniqueness of the individual, the uniqueness of their genetics, the uniqueness of their disease, or of their diseases in a single patient, in order to have really effective therapy. So how you choose amongst all of these things is extremely difficult. That's why the empiricism is as it is. And I'm on the board of directors of a big pharmaceutical company. We have said we're going to go into tailored therapy. We said personalized first, then we said tailored, because personalized is really tough. And so we are trying to build tools here, but it's extremely difficult because of the heterogeneity of the disease. Now I'll put this one down here last, because this is, of course, one of all the rages at the present time. Because immunotherapy is emerging, monoclonal antibodies like Rituxan and Erbitux, etc., have come into the fore. They're very effective where they're very effective, but that's not necessarily in a large number of patients. Some conditions, like lymphomas, respond initially very, very well to monoclonal antibody therapy, but then it tends to fall off, and in fact, the disease becomes resistant. T-cell dendritic cell therapy, Dendrion just recently got approval for a drug called Provenge, and Provenge is a treatment with dendritic cells. These are cells that tell the immune system how to function. And you train them to attack a cancer, and they do a pretty good job. But what is interesting and distressing about most of these therapies is they prolong life, but they do not necessarily increase dramatically survival, at least at the present time. Vaccination is coming to the fore, especially as a means for disease prevention. And we can come back to that if you wish. Now, adjuvants and immune rejuvenation, I won't go into that at the present time. This involves stem cells, and we can talk about that later. And then ablative with stem cell rescue. Years ago, it was thought if you could just simply destroy all of the cancer cells in the body, essentially destroy all the cells in the body pretty much, and then you could rescue them with stem cells. That has not panned out, not panned out very effectively at all, and is only occasionally useful. It is most useful for hematologic malignancies, okay, where stem cell rescue works pretty well. Now, what I want to do in the next few minutes is just say, look, we got to do something different. And one of the things we have to do is start stratifying disease. So your talk this morning really helped me a lot. You talked about patient stratification. Stratifying disease means you identify the reality of N of 1, or at least of very much smaller groups than just all patients fit into a single bill. And there's a young fellow by the name of Vijay Ramakrishnan who is attempting to commercialize an invention by Ron Evans from Stanford. And what Ron Evans did was to build a grid. There are two sets of genes, these are called VNF and HNH and R. And you don't have to know anything detailed about the biology. But this little corner up here shows a homogeneous H and homogeneous V in their genetic profile. And 3.4% of patients are those patients who fully respond to Rituxan for their large cell lymphomas. Now, this may seem a simple little demonstration, but it's critically important. Because what it says is that, in fact, there are some populations where you can get complete responses to therapies if you highly select the patients and if they have the right receptors. In this area here, they are moderate responders, about 30%, but you see still 65% are poor responders. The problem is, for the practicing oncologist, everybody gets Rituxan if you come in with this disease. And that doesn't make any sense at all. Okay? And I'm going to go on to this little case. A second little case of thinking differently. So there's a group of University of Washington, and the principal here who is trying to develop this with the scientists at University of Washington who discovered all of this, found that there is a cell on the protein on the surface of cells, of cancer cells, called CD46. And what is interesting about CD46 is that it's on on every cancer that's been examined so far, on every cancer that's been examined. And it's there in very, very high concentrations. And what CD46 does, it's a very clever little receptor. It actually functions normally in sort of normal research. It functions as a receptor for adenoviruses. So this is how you get infected by adenoviruses. Adenoviruses bind to this receptor, the adenovirus gets taken up inside the cell, and then all hell breaks loose. In this case, the cancer cell is overexpressing CD46 on the surface. It has a normal function in the body, and its normal function in the body is to prevent attack by complement. Complement is a protein part of the immune system that's responsible for guarding your body against injury from outside agents. The beautiful thing is, as you see here with multiple myeloma, you get a very high concentration of CD46 on the cell. If you block CD46 and you have an antibody like Rituxan, which normally would help to kill the cell, the Rituxan effectiveness is increased because you get complement attack on the cell in question. The beauty of that then is, and this is depicted here, for example, and this is the adenovirus. The protein itself is called OgMab. There are the, so there's the CD46 there, all lit up in green. You give OgMab, the CD46 progressively disappears. In 12 hours, it's essentially all gone. And in the in vitro system, complement attacks and destroys the cell completely. Now, every single cancer cell that has been seen so far has a high concentration of CD46. So what would happen if now we start amplifying the impact of the antibody therapies by first giving patients OgMab and depleting their CD46 and increasing the likelihood that you get two mechanisms of cell kill, one by complement and one through the monoclonal antibody itself. Now here's the problem with all of this. You think you can get any of these things funded? Think again. And my own company, I'm going to be talking with them about this, because there are many, many examples out there that are analogous to this, that are not seeing the light of day, because everybody is so caught up with the stereotypical responses that in fact they do not consider these things which are really different. And I can assure you, I know of 15 technologies that are analogous, all of which I think are very, very promising indeed, that are going essentially nowhere and going nowhere fast. The other problem, in my view, is the NIH review system. And believe you me, I've spent many years in that review system extensively. And the NIH review system does not reward really significant risk-taking of this sort. Fortunately, in this particular case, they recently got an SBIR grant, so I'm hopeful that it will move along. But it will move along very, very slowly. And I am worried because I am 66. So there's just a demonstration of it. This is the effect over here of OgMab and an in vitro system. So the last thing I just want to talk about is this. The challenge across the entire field really is the complexity of the system, the very large number of genetics, genetic mechanisms, and especially now, I think, the very large number of proteins that seem to be involved, is how to select among all of these things to realize new therapies, to realize new mechanisms for diagnosis, for prognosis, for stratification. The number of variables, number in the thousands potentially, can we either reduce the number of variables or can we build computational systems that have the sophistication possible to sort among all the variables and tell us what we want to know. I'm going to go through these very quickly because we don't need them. Those are the sort of complex networks that we were talking about before. And I want to go to this slide very quickly to suggest that we need a much more holistic approach to how we deal with patients with cancer. First of all, start building tools to better predict the likelihood of disease at susceptibility, build better risk models, be able to predict the disease better, be able to implement risk mitigation strategies, whether it be nutrition or better lifestyles or even drugs in chemoprevention mode, be able to assess risk more effectively, get better tools for early diagnosis, because surgery then is curative in an awful lot of these diseases, a lot of these conditions. And then this is where the computation comes in, build tools for better disease stratification and patient stratification, to identify targets more effectively, because our targets right now are substantially random, get better therapeutic algorithms, build pharmacogenomic platforms to better select drugs that are suitable for specific patients and for specific conditions, and finally be able to get better prognosis. My own belief is this, that this tack to try to understand the biocomplexity is critical, but it's going to reside in the realm of the academic environment for a long time before it has practical effectiveness in a clinical setting. But we are getting there. Data integration across all data sets is really critical and important. Data integration does not mean content aggregation. It means looking at the relationship among elements of data that are from disparate dimensions. And this is particularly critical. I said here, does the secret lie in the proteins? The sort of stuff that Larry Gold is doing, the reason I'm so excited about it is that it gives us an opportunity to interrogate large pieces of the proteome to start looking for patterns of proteomic expression that are important either for origin of disease or in fact for disease progression and potentially as targets. I personally believe that the secret lies in the proteins, because those are the things that are really bad, if you wish. They're bad actors. It's not just a matter of the genes. And we've seen that with Gleevec in the case of chronic myeloid leukemia. By the way, CML, I thought, stands for chronic myeloid leukemia. It actually means crazy man Larry. And then finally, the essential role of the immune system. I'm betting on this. I am betting that, in fact, one of the things we will do in the near future is be able to rejuvenate the immune system, especially as a function of age or after chronic disease. This is going to come, in my assessment, from the increased understanding of and use of what are called immune adjuvants. For those in the audience who are scientifically inclined, these are agents that manipulate TLR, the toll-like receptors, and manipulate the immune system either to increase immunity or decrease immunity. Decrease immunity, for example, if you have autoimmune disease. Increase immunity if you have immunosuppression or immunoinsufficiency. This is emerging very, very quickly, and some very sophisticated work is being done in the vaccine world, especially. A name I'll give to you is Steve Reed out of a little organization called IDRI, Infectious Disease Research Institute in Seattle, who has some of the best adjuvants in the world. And they've been adopted by Merck, not by Merck, by GSK, in their new vaccine for cervical cancer, basically for HPV. I have seen this work in terms of amplifying immune system. I could see a day where many of us, as we start to age, will get some of our cells packed away in a vault for subsequent immune regeneration. I think it's entirely feasible. I don't think it's just in the realm of science fiction. So I'm hopeful, but I think the messages that I really wanted to leave to you today is just what was said this morning. Cancer is a very heterogeneous disease. There's no such thing as a cancer. I think we need to come to grips with that more and more and more. We need to stop accepting that 20% to 21% improvement in a therapy just because it's done a large number of patients represents real progress. We've got to start insisting that we do something more aggressive and more creative. We've got to start supporting people who are trying to do things that are outside of the box, outside of the stereotypy, and insist that we get much more effective results that are not quite as toxic. And then finally, I would personally like to see a lot more work done on creative models for immune therapy of cancer. We have not made nearly the amount of progress that we should have. I'm finding now in my dotage that this is what I'm going to do, and as I said, it's enlightened self-interest. But it also should be in your interest as well. This is a ravaging disease. The person I told you about with the Burkitt's lymphoma died on Friday, 2 weeks after diagnosis. Thank you very much.
take time for 2 questions, and we'll keep moving up here.
Sure.
Oh, thank you very much, Dr. Prendergast. To make this real quick, had a case of hepatitis for 30 years and got over it through the conventional treatment and shed the virus, but it left some residual scar tissue in the liver and kidneys. And so I was looking for an adjunct type of treatment for that. There wasn't a real AMA protocol. And so I did some research, and it seems like they've been using oxygen, higher forms of oxygen to actually, you can get into your body different ways, intravenously, et cetera. And that actually seems to have helped. There's nothing else really helping, and so I'm not as toxic now. I'm healthier now, having done that, more of a naturopathic type of treatment. So I was just wondering if you could share with us at all maybe some of your experiences at the Mayo Clinic with maybe some alternatives, or if you've heard of maybe oxygen therapies for cancer, because what this was probably developed for was the treatment of cancer, but I was using it for myself to help break down the scar tissue. So thank you very much, sir. Appreciate it.
There's a lot of work going on, as many of you may know, with so-called hyperbaric oxygen for a whole variety of things. One of the problems that I have with that therapy is, of course, it's substantially blind. If you think about what hyperbaric oxygen does, 2 things predominantly is just increase the amount of soluble oxygen. I've seen it work for patients, for example, who have cerebral insufficiency, and patients become much more cognitively engaged very, very quickly. The other component of that is that it increases the probability of getting toxic oxygen radicals. And the hypothesis is that, especially with hydroxy radicals and peroxy radicals, that you're going to get basically a cytotoxic effect, especially on cells that are dividing very rapidly. There is theoretically no reason why this couldn't happen and why this couldn't work. I personally would not want somebody to inject me with peroxide. I think that's not a good idea. But on the other hand, why wouldn't this potentially work? I mean, it's a chemotherapeutic agent. The problem is non-specificity, because you're sending it all over your body, and eventually you may be doing more damage to the rest of your body than not. There are idiosyncratic features to all of this that you can't predict. So as far as I'm concerned, and where medicine is concerned, there's no arrogance in me at all. If it works for you, why not? If I'm desperate, I'm going to try everything. I actually have, I keep telling people that life and death for me is not about my fear of death as my fear of the absence of life. Because I happen to like living, and especially after Evelyn Resch, I really like it. So I'm not picking on Evelyn. I don't see her anymore. I'm actually going to go catch a plane. I'm not coming to dinner. So the answer to your question is, where alternative medicines are concerned, where complementary medicines are concerned, first, do no harm. The Brzezinski treatment that used high concentrations of sodium chloride made no sense. Bluntly, that's harm. But if you like herb tea, if in fact you even think it does well, if you in fact through that mechanism you stimulate your immune system, why not? I mean, this sort of emotional, arrogant hang-up that physicians have doesn't make any sense to me at all.
So you talked about the genetic heterogeneity of cancer, and I think probably you dramatically understated how complex that is, and so that gives you, you're sort of pessimistic about your ability to treat it if you assume that genomics is the way to understand drug targets. But the thing it's, or one observation is that all tumors are made of cells. They still have to be cells. So most of the biology that goes on is the same, or only maybe slightly altered, so that they grow a little faster. But they still have to be cells, which means most of the stuff, I mean, most of the systems in the cell are still working, even though the heterogeneity is there. So the heterogeneity, the origin of cancer may be complex, but the phenotype, at least on cell biology level, may be very similar or more common. And so is it possible that from looking at cancer from a proteomic point of view, and especially looking at regulatory proteins or some subset of the proteins in the cell, cancer may simplify in the ability to come up with novel therapies? more possible.
Actually, I believe exactly what you say. I think that's why I said the secret is in the proteins. My own feeling is, if you think about all the pathways that are involved in cellular proliferation, and they vary from tissue to tissue to tissue. I mean, one pathway will go through AKT, another one will go through a MAP kinase pathway, another one will be regulated through RAS, etc. You do get some specification as you go from one type of cell to the next, and maybe from one cancer to the next. The first thing I'd like to see is a molecular reclassification of cancer. So we get away from this notion of having a cancer of the liver, cancer of the pancreas, a cancer of the lung, and therefore you treat with a specific condition, to looking at the actual pathways within the cell, indicated in part by the genes, but in part and in good measure by the proteins that actually do the regulation. Because the notion that you simply get an increasing protein as a sign of changing regulation in a pathway, of course, is nonsense. Krebs showed that a long time ago. You may not get much change in a protein that is expressed at very low amounts, but nonetheless has potent effects on controlling transcription and potent effects on controlling proliferation generally. So the answer lies there. How we tease it out is the challenge. And as I said, and you do this first with the individual patient, then see if they fit into another paradigm with another larger set of patients. I'm not so pessimistic as I sound. I think the issue is, however, get all the data. This complete, so-called comprehensive integrated data sets across all dimensions, proteomic, I'm not so sure about metabolomic, but certainly proteomic, genomic, epigenomic, and then finding how these things are truly integrated and interrelate, understand the proliferative pathways that you're finding in a particular cell or tissue, and using that to identify your targets for therapy.
Yeah, but I'm wondering whether we have to, I mean, the integration part is interesting, a lot of PhD theses and a few Nobel Prizes, but I wonder whether we even have to go that far in terms of cancer therapy, if you just notice what's going on in the proteome, and especially, as you said, the regulatory part.
It may be that simple. I don't know. I was talking with Larry a couple of weeks ago about the whole question of the correspondence between what you see in genomic expression and what you see in the actual proteomic maps. And there's a difference of opinion. He doesn't find a lot of relationship. Matthias Mann does. Do we need to even worry about that from an empirical standpoint? If we find something that's really dominant, MAP kinase is here, AKT is here, 2 drugs, kill both, bang, you get the cancer. You still have the problem, though, of differentiating how normal tissue is behaving from how the malignant cells are behaving, and therefore whether you're going to get a lot of toxicity. And so I still think the greatest discriminator of individuality, whether it be cells or tissue, is the immune system. And I'm holding fast to that a combination of selective chemotherapy with some biological agent is going to be the best form of best approach. It's partly opinion at this stage. We don't have enough data.
Thank you, Doctor.
Yeah, thanks.